It's a pleasure to be here. I thank you, everyone, for staying late. I was thinking no one's going to be here for this talk. The interesting thing I took from the session today actually is what Dr. Schneider said, that sometimes you can have physician failure as a reason why things don't go well, and I think that this is probably what happened in this case. We're a pretty busy tertiary care center. We had an 85-year-old female. She was transferred from an outside hospital with a 3-day history of mid-epigastric abdominal pain. Very frail-looking 85-year-old lady with the comorbid conditions that you would expect: hypertension, CAD. She had not had any sort of intervention performed, just medically managed CAD. So she had a CAT scan that was already done at an outside facility, and we can run through it over here. And then I'll play it back. So this is what we see on the CAT scan: significant, whether it's a PAU or a mycotic aneurysm, significant abnormality of the aorta just near the visceral segments going down, and then the aorta the infrarenal aorta looked normal. Iliacs were small, calcified, but nothing else. So just going back on this slide. Oops, sorry. See if I can kind of scroll back over here. As you can see, fairly diseased segment. And I think this is one of those cases where she's 85. It's unclear what this is. We obviously, is this a mycotic aneurysm or not? Definitely is in the location. Looks abnormal. She had blood cultures that were negative. We medically managed her, get her blood pressure down. Still continued to have on and off epigastric pain. So you're kind of stuck in this situation where what should you do for an 85-year-old? And she was pretty adamant that she wanted repair of this, obviously for the risk of rupture. I think in an 85-year-old, open surgical options are probably very limited, and no one would do a thoracoabdominal. The other thing you could probably have considered is debranching, which again at 85 with the diseased iliac, it may be difficult. So we went ahead and decided to go do a chimney technique. We do get a fair number of these transfers where they need to be urgently done. We have a pretty good algorithm. We use an SMA. We use an ICAS for the SMA. We routinely use Viabons for our renals, and then we either use a Gore device or a Endologics device, depending on the anatomy that we're treating. We do this with an axillary cut down. I know Dr. Schneider mentioned that they do conduits. We actually do a cut down on the axillary artery. We place 3 purse string sutures, and we directly puncture them with 7 French sheets, and probably done about 40 or 50 of these over the past 2 years. And I think we've had just one complication where the patient had arm ischemia post-sheath pull, which should have been recognized in the OR, but unfortunately it was recognized later on. So SMA was cannulated, everything went pretty good. Looked at all the branches. The renals were cannulated, had our sheath up from below. Had to do a retroperitoneal cut to get the sheath in because of very diseased vessels. Got the ICAST positioned. This is again just showing you a pre-run of what the disease segment looked like. Fairly large looking, either pseudoaneurysm or whatever abnormality you want to describe that as. Was pretty happy. Got the stents in, the graft in, ballooned the SMA. Here's the completion. We use 2 ICAS routinely to get it above. So 259 millimeter. We usually balloon the whole segment. We obviously deflate the SMA stent the last, and obviously inflate it first while we're doing ballooning of the main graft. And it looked pretty good on completion. The area of a disease was excluded. She had a very good GDA, and so we didn't really do anything with the celiac. I figured that the graft would really oppose it at that level, given her relatively narrow aorta. Again, this was a case I was kind of doing late in the evening. I think that probably was not the best decision too. I think there's some degree of fatigue that sets in. So this is pre and this is post. I was like, hey, fantastic. Everything turned out great. She's 85. Brought her out to the recovery room, doing well. Pain's better. Obviously, she was asleep for this. So starts waking up, and over the course of the night, starts developing abdominal pain and an elevated lactate. So obviously, you're like, oh God. So she goes for a CTA to evaluate the patency of the stents. And here's the CTA. And unfortunately, the worst thing that you can kind of expect. SMA stent is essentially crushed. Even the renal stents look pretty compromised. Her celiac is covered. So, horrible situation to be in. So the minute I see the scan, obviously it's in the middle of the night, it's just start cursing. I call Ed, and Ed starts cursing at me too. He's like, "What the hell happened?" So, we had to take her back to the OR. And I think at this point, there was also concern whether there was dead bowel or not. Her lactate was elevated, celiac is covered, so foregut ischemia, midgut, everything is really compromised at this point. And you can see on an angiogram, really the no significant flow. Did a thrombectomy, SMA cut down, opened it up under fluoro, reinforced that portion. Got a much better outcome. I mean, some of these images aren't that great, but here's a sheath in the SMA, and was able to restore flow into that SMA. And I think if you look back, also you can see that the renal stents were also a little bit compromised in this configuration, and I wonder if the aorta was just too small. We don't routinely reinforce the viabonds with self-expanding stents, but occasionally we have when there has been concern. I think in this case, I didn't notice anything, but maybe taking multiple projections may have given me an idea, or even taking a lateral projection on this case may have prevented this complication. And she obviously had a very complicated post-op course and subsequently expired from an MI. So I think this is one of those cases where you're between a rock and a hard place. The patient's obviously symptomatic, and you have to assume that it is the aorta, and this would be an option to treat her. Like I said, we get a fairly significant number of these patients that get transferred over that are symptomatic. So don't really have the luxury of getting fenestrated devices or branch devices because these are done pretty urgently. But I think that this was an error. This was a physician error. I think that probably a little bit better planning and less fatigue could have prevented this complication. I don't have a list of the other cases. I'm sure I've done many other cases where the outcome has been bad, but I think that this was a case where when I retrospectively look back, I think we could have done things a little bit differently. Not that it may not have had to be done, but I think I could have done this a little bit more carefully. And that's it.